The search for durable, root cause solutions to chronic pain is accelerating, and among the most promising developments is the intersection of two seemingly separate domains: cellular senescence and physical rehabilitation. On one side, senolytic therapies aim to eliminate senescent, zombie cells that accumulate with age and injury, secreting inflammatory factors that sustain pain. On the other, physical therapy, PT, works by restoring mobility, strength, and neuromuscular function to reduce mechanical strain and rewire dysfunctional movement patterns. But what if these two modalities, one biological, the other biomechanical, were not competing approaches, but rather synergistic partners in treating chronic pain? Emerging research suggests that combining senolytics with structured movement therapies could offer a dual-action pathway to both symptom relief and tissue-level healing, particularly in musculoskeletal conditions like osteoarthritis, degenerative disc disease, tendinopathies, and age-related back pain. While each modality has value on its own, their integration may unlock therapeutic effects that neither could achieve alone. Let's begin with the biological premise. Senescent cells accumulate in injured or aging tissues, especially in the joints, intervertebral discs, tendons, and skeletal muscles. These cells don't divide, but they don't die either. Instead, they linger and release a cascade of pro-inflammatory, catabolic substances known as the senescence-associated secretory phenotype, SESP. This SESP environment promotes matrix breakdown, attracts immune cells, and sensitizes local neurons, essentially turning tissues into pain generators, even in the absence of acute injury. Senolytic drugs like Fisetin, quercetin, or combinations like dasatinib and quercetin aim to clear these senescent cells, effectively resetting the tissue microenvironment. In preclinical models, senolytics have been shown to reduce pain, restore cartilage integrity, improve muscle regeneration, and even reverse age-related spinal degeneration. However, while senolytics may improve the internal chemical milieu, they do little to address mechanical dysfunction, such as altered gait, muscle imbalances, joint instability, or the neuromuscular adaptations that often accompany chronic pain. This is where physical therapy becomes essential. Skilled PT addresses the external contributors to chronic pain: imbalanced movement patterns, compensatory postures, weak stabilizers, and maladaptive neuroplasticity in pain signaling. Yet physical therapy has limits, especially in tissues where inflammation or fibrosis has already taken hold. For patients with degenerative disc disease, fibrotic tendons, or advanced osteoarthritis, physical therapy can be blunted by a persistent background of cellular senescence that resists change. The key insight is this: senolytics could make physical therapy work better, and physical therapy could make senolytics safer and more sustainable. By clearing out pro-inflammatory cells, senolytics may reduce tissue stiffness, swelling, and local sensitization, lowering the pain threshold that often prevents patients from fully engaging in rehab. Freed from constant inflammatory bombardment, muscles and tendons may respond more readily to loading and stretch. Improved microcirculation and metabolic efficiency could enhance oxygenation and nutrient delivery, further boosting PT outcomes. Conversely, physical therapy may help optimize the effects of senolytics by promoting mechanical loading and tissue remodeling, which are crucial for replacing senescent cells with healthy ones. Many senolytic studies show that tissue regeneration depends not just on clearing damaged cells, but also on encouraging new cell turnover, a process stimulated by exercise and controlled movement. Without this anabolic signal, the benefits of senolytic clearance may plateau. In this way, physical therapy functions as a biological follow-up to senolytics. Movement creates the new architecture that replaces what senolytics remove. Clinical application of this dual strategy is already on the horizon. Imagine a scenario where a patient with degenerative knee osteoarthritis receives a short course of senolytics to reduce synovial inflammation and subchondral bone senescence, followed by a targeted rehab program to strengthen the quadriceps, correct gait imbalances, and restore joint stability. Or consider older adults recovering from spine surgery or disc herniation. Senolytics could reduce the accumulation of post-injury senescent cells, while PT rebuilds core strength and improves proprioception, preventing the transition to chronic pain. Importantly, this combination may also mitigate long-term risks. While senolytics are powerful, their long-term safety, especially in repeated cycles, is still under investigation. Physical therapy provides a non-pharmacological counterbalance, It doesn't suppress immune function or risk drug interactions, and it enhances overall resilience and quality of life. If senolytics can reset the tissue environment, physical therapy can reinforce it with improved posture, alignment, and neuromuscular control, extending the therapeutic window and reducing relapse. There are, of course, practical considerations. Timing will be crucial. Administering senolytics too early after injury could interfere with the beneficial aspects of short-term senescence, such as wound healing, while waiting too long might allow fibrosis and dysfunction to set in. Likewise, initiating PT during the anti-inflammatory phase of senolytic treatment may be ideal, as patients experience improved range of motion and reduced sensitivity. Personalization will also be vital. Not all pain patients are biologically senescent, and not all injuries require systemic senolytics. Future tools such as senescence biomarkers in blood or imaging may help identify which patients will benefit from this dual approach. Ideally, senolytics will be delivered intermittently and in low doses, minimizing risks while allowing PT to do the heavy lifting of long-term structural change. In conclusion, combining senolytics with physical therapy represents a next-generation model for chronic pain management, one that goes beyond symptom suppression to address the biological and biomechanical roots of pain. This dual-action strategy offers a more complete, personalized, and potentially transformative path to recovery, especially for the aging population, where both senescence and movement decline converge. As research evolves, this integrative approach may redefine how we treat pain, not just by managing it, but by systematically reversing its cellular and structural foundations.